So welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED CT Expo 2022. My name is Sarah Warren and I'm a terminologist here at SNOMED International, and I will be moderating today's session. So all questions will be answered at the conclusion of the presentation. For online attendees, please use the Q&A chat box to type in your questions to the presenters. And on-site attendees will pass around a microphone, so just pop your hand up and we can come to you with that. So I'm now pleased to introduce Corey Smith from the American Medical Association, who will be presenting the Gravity Project, New Data Standardization in Social Determinants of Health Data Interoperability. Corey, it's over to you.
Hello, I'm Corey Smith. I'm the Vice President of Informatics and Digital Products at the Integrated Health Model Initiative Business Unit of the American Medical Association. And I'm here to present today the Gravity Project, New Data Standardization in Social Determinants of Health and Data Interoperability. So we're going to cover an introduction to the AMA and our focus on healthcare data initiatives, why SDOH are important, and the primary focus of the presentation today will be on the work of the Gravity Project, and then we'll wrap up with looking ahead. So first, let's just talk a bit about the problem with healthcare data. So in the US, we spend over $3 trillion a year on healthcare, and we are generating more data than ever. And yet, most of that data is often inaccessible and incomplete. And just to break that down further, even if the data were accessible, that's only half of the problem. Oftentimes, the data is incomplete and incompatible. This gets to semantic interoperability. The recipients of data are unable to interpret it correctly, and the data often lacks clinical relevancy, which diminishes its value to healthcare providers in clinical decision-making. So the AMA, who has a long history, we were established over 175 years ago, and with a focus on standardizing healthcare, not data at the time, but in standardizing healthcare more broadly. And today, 175 years later, we are focusing those efforts on improving healthcare data as well. And so in 2016, the business unit that I'm a part of, the Integrated Health Model Initiative, was established due to the recognized lack of high quality data to accurately capture patient function, state, goals, and social determinants of health. And we established a team of recognized leaders. And we advance AMA mission objectives like improving health outcomes and increasing health equity in two ways. First, through the development of open data standards like HL7 FHIR, SNOMED CT, and others. And we also develop software solutions with an emphasis on improving data quality. And we have two such examples here with something called Verify Health SMBP, as well as something called the Social Needs Autocoder, which converts social needs screening responses into ICD-10 codes. And in addition, we also have a long history of over 56 years of developing the CPT code set, a procedural language curated by an independent physician-led process that is licensed in over 40 countries and has maps between SNOMED and CPT. So we aspire to unleash innovative health solutions that address our chronic global healthcare crises and improve health equity. We've realized that no single organization, the AMA or any other single organization, can address these challenges alone. And so we look for collaborative opportunities with engaged and influential stakeholders to address big challenges. And today's discussion focuses on one such highly collaborative and successful project that the AMA has been working on since 2019 as a founding member, called the Gravity Project. The Gravity Project develops consensus-driven standards and social determinants of health and is a FHIR accelerator. So just to kind of root ourselves in one of today's important healthcare challenges, I think this cartoon summarizes it nicely, which is healthcare traditionally focuses on providing clinical care to patients. But meanwhile, there are other things in our lives that impact our healthcare, such as housing, food, etc. First, before we dive in, let's just spend a few moments on just defining some terms as it relates to social determinants of health. And we'll define terms at three levels: a systems level, a community level, and an individual level. So at the systems level, we think of health equity as is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So that's a systems level term, health equity. Social determinants of health are the conditions in which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources. And social determinants of health are community level. It's a community level term. And at the individual level, we think of protective factors, which are characteristics or strengths of individuals, families, communities, or societies that act to mitigate risks and promote positive well-being and healthy development. And social risks, which are adverse social conditions associated with poor health, and social needs, which are non-medical patient prioritized needs that impact health. And addressing SDOH and its various key areas is an approach that can be used to improve health equity and reduce disparities. So why are SDOH important? On the right here, this shows us that from this study, 20% of health outcomes are rooted in healthcare, while the other 80% are rooted in health behaviors, physical environment, and other socioeconomic factors. And more specifically, unmet social needs negatively impact health outcomes. And here are a few examples. So food insecurity correlates to higher levels of diabetes, hypertension, and heart failure. Housing instability factors into lower treatment adherence, and transportation barriers result in missed appointments, delayed care, and lower medication compliance. So more and more of the research is showing that SDOH are really important in health outcomes. There was a study done at by a group called Siren, affiliated with the University of California, San Francisco, that there are multiple uses of social risk data in clinical settings, ranging from population health management to research to community health improvement and more. That study also showed there are challenges in SDOH data capture and exchange. And highlighted in red here are the two primary challenges that the Gravity project is focused on, which are standardization of SDOH data collection and storage, as well as data sharing between ecosystem parties. And while these are just two challenges in SDOH data capture and exchange, we think these are foundational solutions in these areas are foundational to solving the other challenges. So the Gravity project is a collaborative public-private initiative launched in May 2019 with the goal to develop consensus-driven data standards to support the collection, use, and exchange of social determinants of health data. The project's scope is twofold. One is around developing data standards to represent and exchange patient-level SDOH data, documented across 4 clinical activities: screening, assessment, diagnosis, goal setting, and treatment interventions. And then, having developed those data standards, the Gravity project also focuses on testing and validating those data for real world use in patient care, care coordination, and more. And on the right here, you see the 17 social determinants of health domains that the Gravity used on. So now let's just dig a little deeper into how Gravity works and how we completed the work that we did. So there are 3 work streams within Gravity: terminology, technical, and pilot work streams. At the top here, you'll see the terminology and technical work streams work in parallel and in a complementary way. The terminology work stream focuses on defining data set definitions and submitting codes to code systems like SNOMED and others, and developing value sets and publishing those value sets. And the technical work stream, which is an HL7 FHIR accelerator, focuses on use case driven FHIR implementation guide development and testing, and then publishing those guides as part of the FHIR publication process. And the pilot work stream is about testing and implementation of both the terminology and technical works products. So the Gravity project is a public collaboration across the terminology and technical work streams, and has convened over 2,500 participants from across the health and human services ecosystem. In my 20 plus years in doing data standards work, I've never seen such a large collaborative group do so much in such a short period of time. It's really been a privilege to be a part of. The project founders, grants, and in-kind supporters to date are listed here, and come from all of healthcare, providers, social services, payers, technology vendors, governments, and patient groups. A little bit of history about the Gravity Project's timeline. Prior to the launch in 2019, there was exploratory work within the Siren project at University of California, San Francisco, and with some funding from the Robert Wood Johnson Foundation, that led to the launch of the Gravity Project in 2019. In 2019, we did the first domain, which was food insecurity, and the project became an official FHIR accelerator. And then over the last few years, we ramped up the domains, the terminology domains that were covered, and we built out the Gravity implementation guide, and published it as standards for trial use level 1 and soon level 2, and also had some success in publishing the work in other places within the NLM and within the US core data for interoperability. So let's talk a little more about next sections here about talking a little more about the work of terminology, technical, and pilots, and we'll talk first about terminology. So the terminology workstream accomplishments include defining codes for multiple code systems across many of these domains. So screening codes for 15 domains in LOINC, ICD-10 code, Z codes in 12 domains, and the list goes on. You can see here on the right in terms of where things are being coded. In LOINC is being used for coding the screening assessment instruments. SNOMED and ICD-10 are used for diagnoses. LOINC and SNOMED are used for goal setting, and CPT and SNOMED are used for interventions. So this slide shows us how we do in a particular domain, what the terminology build looks like. So the LOINC screening and assessments is where we capture where the questions and answers are captured and codified in LOINC, as you see up here in the right-hand corner in orange. In SNOMED and ICD, we can see where we're codifying the food insecurity observation and the food insecurity diagnosis here in ICD-10-CM. We're also coding the goals, in this case, food security in SNOMED. And then on the left-hand side, you'll see a range of interventions that are used to address social needs for food insecurity, including screening for services, education, et cetera. And a little more about the interventions framework. As the project worked through the 17 domains, we think about the interventions as falling into 9 different service categories, if you will. And this gives you some sense of how those interventions are being approached in each domain, from providing assistance to coaching, counseling, education, and provision and referral. So terminology activities that are under consideration for 2022 and beyond. New domains are being considered around discrimination, bias, and racism, green space, adverse childhood experiences, and other terminology activities. So let's talk a little bit about the technology work stream. The HL7 SDOH clinical care FHIR implementation guide is one implementation guide that facilitates exchange across all of those 17 domains. We call this a framework implementation guide because it supports exchange across all of those domains. And the IG supports the following clinical activities really around closed loop referral assessments, health concerns, goals, interventions, consent, aggregation, exchange with patient and client applications, and there are also now draft specifications for personal characteristics, including race and ethnicity. And again, the guide was first published as a standard for trial use level 1 in August of 21, and we will be publishing the STU2 version, which was balloted this year and will be published later this fall as a standard for trial use level 2, excuse me. So again, you'll see the similar patterns here that we saw in the terminology work stream, that as we work through each of those clinical activities, from screening to observation and diagnoses, to goal setting, interventions, measuring outcomes, and establishing cohorts of patients with common SDOH characteristics for uses beyond the point of care, and also some managing consent. These were the use cases that drove the development of the FHIR implementation guide. So bringing it all together in the pilots work stream, so the standards work within Gravity is focused on widespread adoption and use, real world use of these standards. We don't like to build standards that just get put on shelves. So the pilot project is intended to define incremental tiers for testing Gravity standards, both terminology and technical. And we took a tiered approach to allow for different types of entities, even those with limited health IT standards adoption, to participate and do meaningful testing. So tier 1 testing is the minimum bar, and it's really about testing just the terminology standards. Tier 2 is about testing the terminology standards, as well as some form of electronic information exchange, which isn't FHIR based. So perhaps folks are already exchanging data via some older HL7 standard like CDA or some other electronic means that isn't FHIR. We're still interested in how folks can effectively use the Gravity standards, terminology standards in those contexts. And tier 3 is really bringing all the pieces together, where folks are testing not only the terminology, but the exchange of the terminology using the FHIR implementation guide. So we are actively seeking participation in the pilot's affinity work group to do testing at any of those tiers. We will be having a monthly webinar, which actually kicks off on Thursday, the 29th, I think, is our first call. So there's time to join, even if soon. And if you're interested in joining, even though the Gravity Project is a US group, I think there is applicability of some of the work we've done beyond the US. And if you're interested in participating in any way, you can follow the link here or send an email to the address provided. So we have some ongoing pilots already with Gravity that are funded by the Office of the National Coordinator in the US, as well as some grant money. And those pilots are listed here. So let's talk about how we measure success in Gravity. And in standards in general, I really like this framework for measuring success in data standards. So we think about success as the integration of data standards into grants, into practice, into innovative tools, policy, payment models, other programs, and other standards. And Gravity has already achieved a lot of success, as I mentioned, in a relatively short period of time. And here is a list of some of those successes, including inclusion in the US core data for interoperability, some payment system within CMS, Centers for Medicare, as well as inclusion of Gravity standards into 3 federal grant programs: the Administration for Community Living, the ONC LEAP grants, and the Administration for Children and Families. So this list continues to grow. How to engage. So again, the Gravity Project is dependent upon, we've had the success we've had within the Gravity Project because of the tremendous participation from our community and stakeholders. And anyone who is interested in joining the project, you can learn more about how to do that following the various links and information provided here. Thank you.
Thank you, Corey. And we should be lucky enough to have Corey join us online. So as a reminder, if you're in the room and want to ask a question, if you pop your hand up, we've got a microphone that we can bring to you. We do have a couple of questions online to start with first. So the first one is, Corey, what are the new social determinants of health codes getting approved?
Hello, everyone. Can you hear me?
Yep.
All right. Good afternoon. So I don't know the specific codes that are in progress now, but as I mentioned, there are a number of domains across the 17 domains that we're working on that are still being processed by ICD-10, SNOMED, and others. So that's, I think, the best. There are still codes in process, but I can't tell you exactly which ones are still in motion, unfortunately.
Great, that's great, thank you. Our next question is, how do we get involved in the Gravity project if we want to?
Yeah, absolutely. If you go to thegravityproject.net, that all of the information you need to participate can be found on that website.
Super, thank you. So we'll just have one last call out for questions in the room. Anybody? No. Oh, we've got one question at the back. We'll just bring you a microphone. Just at the back, this gentleman.
Thank you. I'm a GP, and so for me, it's a very important domain. And I try to map, I used to use ICPC2 for there is a social chapter with every determinant of health problem inside. There is 29 financial problem, alimentation problem, and so on, food problems, and so on. And I try to map this social chapter of ICPC2 to SNOMED CT. And I think this is one of the, I find this is one of the chapters with the most lacking information. It's 50, the half of the code are not in SNOMED CT. For example, for the skin and biomedical over anatomical things, there is about 75 or 80% of the code are in SNOMED. Do you find this kind of results also? How do you deal with that?
Yeah, I mean, I think the Gravity project, I think, is focused on, kind of a top-down coding. So let's get coverage across the domains at least at the higher, more coarse grain level, and let's build out more detailed concepts over time to represent more granular meaning. In terms of how to deal with that, I think, from a mapping perspective, if you have a more granular code, in ICPC, you could, map to a broader code. I would expect that at least at the domain level, that there should be coverage in most of the domains, and you could map do kind of a narrow to broad map, at least to get some coverage. And as SNOMED fills out the content at the more detailed levels, you can update those maps to be more specific.
Thank you. Any other questions in the room? No. And with that, we'll conclude the session. Thank you again, Corey. Online delegates can join another session through the event lobby. And thank you everyone for attending. Thank you.
Thank you all.